Welcome to the deep dive. Today, we're zeroing in on something practical for those of you already experienced with hyperbaric oxygen therapy, HBOT.
That's right.
We're focusing on transcutaneous oximetry, TcPO2, and specifically how you can use it to really sharpen your approach, both for, picking patients and for monitoring treatment.
Exactly. The idea is to look at how TcPO2 gives clinicians, like yourself, real tangible data. We're talking tissue-level oxygen changes during HBOT.
Right.
And we'll look across various conditions where it's used. We're pulling this straight from the sources, highlighting the applications, but also maybe some of the nuances, things that can make a difference day to day.
Okay, great. Let's get straight to it then. Now, most listeners using HBOT will know TcPO2, but maybe a quick recap. What exactly is it, and how does it fit into the whole HBOT picture?
Sure. So TcPO2, it's non-invasive. That's key. It measures oxygen tension right there in the skin's capillary. Think of it as, well, an indirect window into peripheral oxygen delivery and tissue perfusion. It usually uses a modified Clark electrode, with a little heating element built in.
Ah, the heating element. That's not just incidental, is it? It's actually important for the measurement itself.
Absolutely crucial, yeah. The heat does a couple of things. It makes the skin more permeable to oxygen, lets it diffuse easier, and it also affects the local oxygen consumption right under the sensor.
Okay.
So the temperature you set the electrode to, it directly impacts the reading you get.
Mm-hmm.
Ultimately, what you're reading reflects arterial blood gas tensions and, crucially, how well oxygen is actually getting out to the tissues.
Right, the delivery part. Now, with HBOT, we're obviously cranking up the oxygen levels in the blood significantly. How does TcPO2 help us see the effect of that down at the tissue level?
Well, HBOT, as you know, dramatically lifts the partial pressure of oxygen in arterial blood, the PaO2. This means way more oxygen gets dissolved directly into the plasma.
We're talking like orders of magnitude more.
We're talking 10, maybe even 20 times higher than breathing room air. It's a huge jump.
Wow.
And this hyperoxic state is what forces oxygen deeper into tissues that are starved for it, the hypoxic ones.
Mm.
Now, what's really useful about TcPO2 monitoring here, especially if you establish a good, stable baseline reading somewhere reliable, like the subclavicular area.
Like a reference point.
Exactly, a reference point. It gives you an objective way to see how well all that extra oxygen you're delivering under pressure is actually getting to the tissues.
So it bridges the gap between theory, more oxygen in the chamber, and reality, more oxygen where the patient actually needs it.
Yeah.
Okay, so where does this become really valuable for making those tough clinical calls about using HBOT?
Patient selection is a big one. Take problem wounds, chronic wounds. A lot of them are fundamentally hypoxic, right?
Right, lack of oxygen is often the core issue.
So TcPO2 gives you a reliable way to measure that baseline tissue perfusion under normal air conditions.
Yeah.
But more importantly, it lets you see the potential for improvement during a test dive or the actual therapy.
That makes total sense. You'd want some kind of objective sign that HBOT actually has a fighting chance for this particular patient, this particular wound. The sources seem to back this up in a few areas.
They do. Consider limb injuries where circulation is compromised.
Yeah.
Research shows that doing TcPO2 measurements while the patient is breathing pure O2 at 2.5 atmospheres absolute.
So under hyperbaric conditions.
Yes. Those readings can actually predict the final outcome pretty well in major vascular trauma. That's huge. It can really help decide if HBOT is even a worthwhile path to go down.
So it's less about could HBOT help in general and more does the TcPO2 response suggest it's likely to make a meaningful difference here?
Precisely. You get a physiological indicator. And for things like pedicle flaps, diabetic foot lesions, critical limb ischemia with those nasty arteriosclerotic ulcers, TcPO2 is a really solid tool, not just for prescribing HBOT initially, but also for checking if it's actually working as treatment progresses. And interestingly, some studies found that if TcPO2 drops below, say, 15 kpi, that's about 112 millimole He, and stays there.
That sounds quite low.
It is. It can lead to anoxia and pressure sores in just a couple of hours. So TcPO2 even has a basic role in just flagging that kind of risk.
That 15 kPa threshold really hits home how fine the line is with tissue oxygenation. The sources also mentioned some specific studies, didn't they, in PVD?
Yes, several. There's work using it in patients with obliterating atherosclerosis in the legs. Other studies looked at how TcPO2 changes when you give someone oxygen to breathe, using that change to predict where an amputation might need to happen.
A predictive tool, essentially.
Kind of, yeah. And also looking at how quickly TcPO2 recovers after you temporarily cut off blood flow, the post-occlusive recovery time that gives insights into peripheral vascular disease severity.
Right.
And of course, we keep coming back to it, but assessing non-healing diabetic wounds, that's a really common application, well documented. Each example just shows how TcPO2 offers objective numbers to back up clinical judgment.
Okay, so that covers patient selection and prediction quite well. What about managing the patient during their HBOT course? How does TcPO2 help there?
Yeah, this is where this sort of real-time aspect shines.
Yeah.
You take measurements simultaneously. One at that reference site we talked about, subclavicular is common.
The baseline.
The baseline, yeah.
Yeah.
And another one right at or very near the wound or tissue you're concerned about.
Okay.
By comparing those two during the dive, you can see directly if that high-pressure oxygen in the chamber is translating into better oxygen delivery where you need it most.
So it's not just assuming that because they're in the chamber, the target tissue is getting the benefit. You need proof.
You really do. Seeing that TcPO2 number climb at the wound site during the HBOT session, that's your direct evidence that the therapy is doing its job, increasing tissue oxygenation right there. It lets you, track progress more objectively. You can see how the tissue's oxygen status changes over the course of treatment, hopefully reflecting healing.
Let's drill down into some specific clinical scenarios then. Chronic vascular wounds, ischemic lesions, these seem like prime territory for pairing HBOT and TcPO2.
Absolutely. For those, the European Committee for Hyperbaric Medicine consensus back in 2004 really emphasized HBOT's role in getting oxygen back to hypoxic tissues. TcPO2 is the objective measure to confirm you're achieving that.
Okay.
It's especially useful, say, for ischemic ulcers or gangrene, when maybe surgery isn't an option, or when healing just stalls even after surgery. TcPO2 helps guide if HBOT is still warranted.
And what about compromised skin grafts and flaps? Oxygen is obviously critical there for survival.
It is. Grafts, initially, they're just relying on oxygen diffusing in until new blood vessels grow, right?
Right. Neovascularization takes time.
And if the underlying blood supply is really poor, HBOT might be limited. But some studies do suggest that hyperbaric oxygen can reduce the amount of tissue death, the necrosis, even in flaps that are almost completely anoxic.
Interesting.
So TcPO2 could potentially be used to monitor that oxygen diffusion into the graft, to flap itself, and maybe the surrounding tissue too. Give you an early clue about whether it's taking.
How about acute situations like crush injuries?
Yeah, for crush injuries, a common HBOT protocol is something like 2 atmospheres absolute, 100% oxygen for 90 minutes.
Standard protocol.
Pretty standard. You could definitely use TcPO2 monitoring there. Measure before the dive, during, after. See how the tissue oxygen levels respond. It might help guide how many treatments are needed or how long they should be based on that individual response.
Okay. Refractory osteomyelitis, that's always a challenge. Any role for TcPO2 there?
It's a tough one, yeah. We know bone oxygen levels are low in osteo, and the whole point of HBOT is to boost that oxygen to help fight the infection and make antibiotics work better. Now, the sources we looked at didn't specifically highlight randomized trials using TcPO2 as the main outcome measure for osteo, but you could argue that measuring TcPO2 in the tissues around the infected bone, or maybe the skin directly over it, might give you some helpful adjunctive information, an indirect sense of whether oxygen delivery to the general area is improving.
Sort of a peripheral indicator?
Perhaps, yeah. Supplementary data.
We've mentioned diabetic foot lesions a couple of times. It really seems central there.
It really is a cornerstone application. As we said, TcPO2 is valuable both for deciding if HBOT is appropriate for that specific diabetic foot ulcer, and then for tracking how well it's working over time. It's used quite extensively.
Okay. What about some of the other conditions where you might use HBOT, say radiation tissue damage or CO poisoning or even necrotizing infections? Does TcPO2 add anything for experienced clinicians there?
Good question. For radiation damage, the sources didn't draw a direct line to TcPO2. But the underlying principle is the same, right? HBOT aims to fix the hypoxia.
Right. Improve oxygenation for healing.
So it stands to reason TcPO2 might be useful for assessing just how hypoxic that irradiated tissue is. Needs more research maybe, but the logic is there.
Makes sense.
For CO poisoning, the main thing you're looking at is carboxyhemoglobin levels, obviously. But TcPO2 could potentially reflect the overall improvement in oxygen delivery to all tissues once the CO2 is cleared by HBOT. Again, maybe an adjunct measure.
And the really nasty ones like necrotizing fasciitis or gas gangrene.
There, HBOT is critical for pumping oxygen into the tissues to stop those anaerobic bacteria. TcPO2 measured in the healthy tissues surrounding the infection might give you some idea of how well that oxygen is penetrating towards the affected zone. It's about creating that hyperoxic barrier.
So it sounds like TcPO2 is a really useful tool, adds objective data across the board. But surely there are limitations, things clinicians need to keep in mind.
Oh, absolutely. It's not a magic bullet. You have to be aware of the limitations. The skin itself is variable, right?
How so?
Well, skin thickness varies depending on where you measure. The location matters. Skin has its own oxygen permeability, its own oxygen consumption rate, all that can influence the reading.
So the number you get isn't absolute in a vacuum.
Exactly. And we mentioned before, but getting that electrode heated properly and consistently, it's absolutely vital for accurate readings. If it's too cool or too hot, your numbers are off.
Consistency is key.
Totally. And maybe the biggest conceptual point, TcPO2 tells you about oxygen delivery to the tissue, reflecting perfusion. It doesn't directly measure oxygen inside the cells or tell you anything about how the cells are actually using that oxygen, the metabolic activity.
Right, so it's a crucial piece of information, perfusion, and delivery, but it doesn't tell the whole cellular story. It needs context.
Precisely. You always have to integrate the TcPO2 reading with everything else you know about the patient, their clinical picture, other tests, how they're responding overall.
Okay. So to wrap this up for the experienced HBOT clinicians listening today, what are the main takeaways on using TcPO2?
I think the core message is TcPO2 is a valuable non-invasive tool that can genuinely enhance your HBOT practice. It gives you objective data. That helps identify patients with significant tissue hypoxia who are probably the best candidates for HBOT.
Better patient selection.
Right. It can help predict outcomes, particularly in tough cases like limb ischemia or those difficult diabetic foot ulcers. And crucially, it lets you monitor in real time during treatment if you're actually improving oxygen delivery to the target tissues.
Which allows for a more responsive approach.
Exactly. More tailored, more responsive treatment.
So even with those limitations we discussed, skin factors, heating, what it actually measures its ability to reflect tissue oxygen perfusion makes it a really practical, informative part of the HBOT toolkit.
I completely agree. It adds an objective layer that can really refine your clinical judgment and help you personalize those HBOT protocols for better results.
Great. Well, here's something for you, our listeners, to think about as we close. We're always seeing advances in non-invasive monitoring, aren't we? So how might future tech refine this even further? Could we get even more precise ways to assess tissue oxygenation, maybe closer to the cellular level, leading to even more individualized HBOT?
That's the exciting frontier.
And thinking about research, what specific studies do we really need to nail down those TcPO2 thresholds? Definitive numbers for different conditions that tell us, yes, HBOT is strongly indicated, or this patient is responding well. Lots to still explore there. Thanks for diving deep into TcPO2 and HBOT with us today.